My name is Peter Balogh, Dr. Peter Balogh. I'm one of the surgical mentors and instructors with the Vancouver AAID MaxiCourse. I'm honored to be here today with Mohamed Sharawy, one of the past founders of the AAID MaxiCourse 27 years ago, and also the director at the MCG's School of Dental Medicine. Dr. Sharawy is a world-known anatomist, pathologist, oral surgeon, and we just finished our weekend here of cadaver courses here at the Vancouver AAID MaxiCourse. And just as finishing things up here, we just wanted to share a few thoughts and questions from Mo as far as where he thinks things are going as far as surgical anatomy and as far as dental education and also implant education. So first of all, Mo, just a quick question. As dentists, we all learn anatomy. We all learn some anatomy in dental school and hopefully remember some of it. But what's the difference between what you're teaching and surgical anatomy versus the anatomy that we might learn in dental school?
Yes, anatomy in the dental schools and medical schools are more of a descriptive courses that try to teaches you all kinds of facts, but it may or may not relate to your practice, you see. Then after you graduate, you need to focus on things that are very important for your practice, and so anatomy is a foundation of dental practice and medical practice. And so what we have done is we designed courses to people, different specialists, that we know what they do in practice, and then every part of the practice we try to support with knowledge related to anatomy. So for example, maybe some of the dentists, after they graduate, they would like to do a good physical examination of the head and neck. Mm-hmm. And then we have to incorporate that in the practice on the surgical anatomy course. Now we have cone beam tomography, we have CT scan, we have an MRI, so the anatomy become more vivid and essential for planning, treatment planning. Then we incorporate more knowledge related to that we never mentioned during the descriptive anatomy for undergraduate students. Mm-hmm. And because they didn't know what they were going to be, so they might be a pediatrician or pediatric dentist or endodontist, and we don't know what they will be, but the people that take our surgical anatomy courses, they know and we know what they're doing, and so we design things related to complications that we know, like hemorrhage, like airway management, like spread of dental infections. We go over details of nerves, which nerves get injured more, how can we avoid that. And not only that, the beauty of these courses that we offer is that you listen to this didactically, but then you go to the lab and you participate yourself. And so you do certain things like harvesting bone from cadavers, doing a sinus lift procedures. You repeat some of the procedures that you learn, but with knowledge now. Mm-hmm. So when we start, we cut, for example, we expose subcutaneous with the facial artery, facial vein, and the marginal branch of the facial nerve. Then we go intraorally, do mucopreosteal flap, and see the proximity of our preosteal elevator to these vital structures. Mm-hmm. And we show them where the lingual nerve, so when you're removing an impaction and putting an implant, how to avoid that. We show them the relationship with the facial artery to the lingual cortex or sockets, so you will not get that. We teach them a lot about the maxillary sinus and the lining of the sinus and what types of grafts will go in the sinus. And then we teach them bone physiology, bone anatomy, bone pathology as a tissue. Then we go over the maxilla and the mandible as an organ, teach them everything related to the maxilla and the mandible, like arterial supply, venous drainage, lymphatic drainage, anatomical landmarks. So it's a very rich course that we do. We used to have 4 days, but now we have 3 days. The 4th day we used to do grand rounds. Great. You know, yes. Get clinical tissue course and all that. So we have done it. You know, I have done it maybe hundreds of times. You know, all over the world. You know. Mm-hmm. So.
Having just kind of completed this as a surgical instructor too, my take on it is it's a very practical, applied anatomy as opposed to a rote memorization of nerves, cranial nerves in different areas. It's we're literally looking at a site from a surgeon's eyes as far as what am I really looking at when in a surgical area, and it's applied as opposed to more theoretical. Do you see this as having an effect or change in even the way they teach anatomy in the dental schools in the undergrad level or in the graduate level?
Yes, I think what happened is that when I started in dental school, I designed courses called applied anatomy. That's different than the surgical anatomy. And applied anatomy is like if I want the students to learn more about the trigeminal nerve, then I talk about trigeminal neuralgia as a start. Then I use that as an opportunity to go over the anatomy of the trigeminal nerve. That's different than surgical anatomy. Surgical anatomy is things that you do, you know, with your hands. You cut on tissues, you cut on bone. That's surgery, or removing a gland and putting. That's different than to do to undergraduate student that doesn't know what it's going to be in the future. So I always have taught applied anatomy, and I published that in 1973. Lengthy articles that people adopted related to how to teach anatomy to dental students, and we do the same for medical students too. The unfortunate thing now is that anatomy participation laboratory is very expensive to develop. Having donation cadaver and having curators to help embalm the cadavers in place, it's costly to schools. So we have 5 dental schools in the United States, new ones, that have deleted the participation part of the gross anatomy. So they have taught people just the didactic anatomy. So that's a step backward, in my opinion. And many of their graduates have a hard time getting into good residency, because the residency, like if you're seeking oral maxillofacial surgery residency, for example, and you don't ever touch the human tissues, and you don't know relationship and where the nerves are, where the vessels are, and then correlate that to your X-ray finding with the CT or MRI and all that, you're lost.
Right.
Yes. So then you'll find a resident bright with 3.8 or 4.0, but then he's stuck. You know, he doesn't know how to apply things. I want them, when they palpate tissues, they know what's under the skin.
Yes.
At least. I want that relationship to the bone and that they are going to access. And I found it very difficult to handle complications if you don't know detailed surgical anatomy, if you're going to be a surgeon.
You mentioned an important point is having the clinical experience, whether it's on, hopefully on cadavers first as opposed to real life patients, because when you just learn didactically that it's hard for our brains to kind of translate what we see in a two-dimensional picture into a three-dimensional person. And my recollection of surgical anatomy textbooks is lots of colorful pictures and everything else, but nothing ever looks quite the same in the diagram. And what you teach in the surgical anatomy course is also quite different. It's a lot more focused on certain particular areas. Are you aware of any textbooks available right now or up and coming which might be more helpful to those, especially people doing head and neck surgery, such as oral surgeons and dentists and implantologists, whereby they can take that analogy, that information, and apply it and have it in an applied sense in a textbook as opposed to memorizing it?
Unfortunately, most of the surgical anatomy books are written for general surgeons and plastic surgeons, and very rare you find something related to dentists. But I'm helping one of the major contributors to a book, surgical anatomy book, done by Len, I don't remember his last name, Testino, from Los Angeles. And he's writing a very thorough book, you know, and in March or April this next year we'll have it. That's one thing. But I'm doing more on the online, you know, online courses, and I'm really having also dissection, prosection myself that I do related to surgical anatomy as an online program. So many of you will find out that this will be available very soon. Then I have podcasts that we've done for clinical examination, correlating that to the neurological exam, like examination of lymph nodes. And with collaboration with San Antonio, I have also several programs, like 4 programs developing into this that people can access online, because that's the trend now.
Okay, so it sounds like there are things up and coming for anybody who does want to expand their surgical knowledge and experience in surgical anatomy. So there are things coming.
See, one of the difficulty also, because you said that things are not what you want. I was trained as a dentist, oral maxillofacial surgeon, and anatomist at the University of Rochester Medical School. And very few, and we wanted to have clinical scientists like that, you know. But then we don't have good training programs. Things decline. We used to have a program in Rochester, at Yale in the United States, and at Harvard. And now we have only the University of Rochester graduating people and no applicants, you know, to do it. So we're declining in number, and we're also declining in quality, you know, on this. So unless we start another training programs like this, you will have a very hard time. You will have the desire, but you don't have somebody that can apply it, you see. I have many anatomists in my department, but they will not be able to do the course I'm doing. Not because they are very, very smart, but how would they know if when they've never seen an implant, or they don't know what's involved in placement of implants, you see. And so they are useful in telling you descriptive anatomy, but that's not, we don't want to do that again, because you can do it on your own, you see. So,
okay. Well, thank you so much.
You're quite welcome. I'm very happy to be in Vancouver, because that's one of the best programs in the Maxi courses, because many other programs have decided not to use surgical anatomy laboratories, and I'm very unhappy about that, you see. But Vancouver is one of the very strong programs that maintain that kind of intensity. And I can see it in the dentists that come to us. You know.
I can see it myself as a dentist, implant dentist, and doing surgery. Even this is my 3rd time doing the cadaver course with yourself, and each time I come away with just that much more knowledge, because every time you see something a little different.
The other thing, I'm not trying to be critical, but the other thing, the last thing I'm going to say, that some of the cadaver courses are not related to anatomy. They teach them the procedures, so it will be the same mistakes again. Like they don't show them where are things and how to avoid injuring it. They show them the same procedure. So you have a mouth, and you have a piece of, you can do it in a model, and they put an implant, and they are very happy knowing how to drill, and then put an implant. But then they don't show them how far you're from the facial artery, how far from the inferior border, what happened as a complications, what happened with that. And so that's a trend now. You know, you have a lot of people with no credential knowing anatomy themselves, but then they're teaching the clinical procedures, so that perpetuate what we don't want to happen. We want them to know a lot of background, so they have confidence. Then the procedures can be done. It's like dental school. You know, they train you into things that you'll never do, waxing up and setting up teeth and all that stuff. And then at the end, you're not going to do it. You see?
Okay.
Thank you so much.
Thank you so much. Thank you.